Mic on. So my name is Corinne. I'm a nurse practitioner, clinical services manager with Optum, and I work with Lisa. And today I'm going to present hypodermoclysis, or shortened clysis. Does anybody know what clysis is, or have you heard about it before? Okay, so this is going to be new material. So let's get started. So today our objectives are going to be to define what hypodermoclysis is, state the 3 indications for use, 3 contraindications for use, list the optimal infusion sites, and discuss monitoring responsibilities and documentation responsibilities. So what is hypodermoclysis? It's a subcutaneous administration of fluids. We just call it shortened clysis. And it's actually been around for a really long time. The Italian physician Cantani started using it in 1865 subcutaneously during the cholera epidemic in Venice in 1886. And it's been used here in this country in the last years of the 19th century. It kind of fell out of flavor in the 1950s. We saw at that time inappropriate infusion rates and inappropriate patient selection, and then also with the start of IVs, so it fell out of flavor at that time. But it came back in the 1980s, but it's often overlooked as an alternative to IV fluids. And few clinicians know enough about it to feel comfortable prescribing the clysis. And few nurses have had education in-service, so that's why we're here today. So clysis today, what does clysis today look like? It's improved, improved with the equipment and the technique. Clysis is frequently used as a part of palliative care. And if any one of you have pets, if you've taken your pets to the vet, they do this quite frequently for our furry pets. So there's a picture of what clysis used to look like. Kind of looks uncomfortable, old, big needle. And today, what it looks like. And then after the presentation, you can come on up and take a look. I have the actual kit you can play around with and look at. So to discuss the normal aging, what happens as we age? We have a decreased total body water, decreased intracellular fluid. The elderly often have reduced perception of thirst, decreased glomerular filtration rate of the kidneys, and decreased renal capacity to dilute and concentrate the urine, and some other physiological factors that come into play: abnormal secretion of vasopressin, increased natriuretic hormone secretion, decreased plasma renin activity, and decreased aldosterone production. Whew, made it through that. Normal aging. So the elderly are more likely to have multiple chronic illnesses. They take multiple medications that affect their fluid and electrolyte balance, and other factors that contribute to dehydration, inability to obtain or drink fluids, and fear of being incontinent. The elderly might limit fluid intake. Advantages of using the clysis: it's easily inserted, it's less invasive than an intravenous catheter, it's easily maintained, it's more comfortable for the patient receiving rather than an IV, it's less restrictive to the resident's mobility, and it can be administered at sites that cannot be easily reached. Advantages: it doesn't require a whole lot of specialized training. It doesn't cause thrombophlebitis like an IV site. It requires less nursing time. It prevents unnecessary hospitalizations for dehydration, that we can manage those residents here in the home. It prevents unnecessary ER transfers if you just need to transfer someone for venous access. It's less likely to cause adverse effects. It can be started and stopped at any time. There's no risk of clots, and it's cost-effective comparative to intravenous therapy. Disadvantages of Clysis. So there is a limitation on the volume of fluid that can be infused at one time, and medications cannot be administered through a Clysis line like you would an intravenous line. Indications, who could we use Clysis on? So your resident with mild to moderate dehydration, it can prevent dehydration, and any resident that has difficult venous access. The contraindications, the obvious, if there's fluid overload, we're not going to be giving anyone any extra fluid. If you have to administer IV antibiotics, then Clysis is not indicated. Severe cachexia, where there might not be enough subcutaneous tissue or fat to insert a needle. Anasarca, so there's massive amounts of fluid in the third space where the Clysis fluid would not be absorbed. If there is electrolyte imbalance, and the more obvious, shock, severe dehydrations, and emergencies such as severe shock with dropping blood pressure. The target population for Clysis is right here, our elderly with poor venous access. It's often difficult to start an IV. Any elderly requiring frequent IV reinsertion, you could consider just using Clysis. Elderly with dementia, elderly with vomiting and diarrhea, mild to moderate dehydration, and when we suspect there's an infection, we need to give fluids, most commonly like a urinary tract infection. So the IV solutions, what could we use for Clysis? So any isotonic solution is appropriate to use. So the most common, what we use every day, normal saline, D5NS, D5 half NS, D5 quarter NS, D5 LR. So there's pretty broad range which you can use for Clysis. And what's inappropriate, so the hypotonic solutions, D5W, do not go through Clysis, hypertonic, D10W, and 3% normal saline.
What about just regular LR?
Yes, yeah, that would be okay. Infusion rates, so the rates should not exceed in one single site 80 milliliters per hour. So if you have to give someone faster than Clysis, it would not be indicated. And you can't give more than 2 liters in 24 hours in a single site. You can have 2 sites at one time, dual sites, not to exceed 124 milliliters an hour, and 3 liters in 24 hours max in 2 different sites. Infusion is done via gravity with the standard IV administration set, a manual flow control device, an infusion device, but not via pump. And up here, you can take a look at what the kit actually looks like with the infusion device. Site selection, so where are we going to put the Clysis needle? Anterior lateral aspect of thighs, outer upper arms, anterior chest wall, the lateral abdominal wall, at least 2 inches away from the umbilicus. That's probably the site I've seen most common, or the interscapular area. This area might be very useful for the elderly with dementia, and that might be pulling at their line, so it's harder for them to reach. Sites to avoid, any area irritated by movement, scars, bruises, areas of edema, painful areas, infected areas, any area of skin breakdown, bony prominences, and breasts. Site rotation. After 2 liters at a single site use, you want to rotate that site, or after 3 liters at a dual site, in at least 24 to 48 hours and PRN with new sites, and at least 2 inches from the previous insertion site. And any time when you suspect there might be a complication. Change the dressing with every site change and as needed. So the monitoring of the crisis site, monitoring every 2 hours, and the usual monitoring similar to an IV site: redness, pain, swelling, leaking, dislodgement of the needle. Adverse effects can be similar to those with IV therapy, but occur less often. So you might see some mild subcutaneous edema, you might see some redness, there could be an infection, but highly unlikely. There could be some discomfort, inadvertent venous access might accidentally lodge into a vein, or pulmonary edema, which is extremely rare if chosen appropriately. Documentation, so you want to address it in the care plan, in your nurse's notes, date, time of insertion, the solution type, the rate and duration of infusion, the site where you started the insertion, assessment of what that site looks like, any complications, and any teaching. And in conclusion, so crisis is safer, easier, and less expensive than IV hydration. Benefits are numerous and disadvantages are few. Crisis should be considered regularly for any elderly in long-term care. And that's it. Any questions?
You just clean the floor hex or something before insertion, is it in the kit?
Yeah, there's actually in the kit here, they have a setup here, and we can, there's ChloraPrep insert, alcohol prep pads, and we do have, through Omnicare, they do have a whole procedure which will be available to you, a policy to follow, how to initiate a subcutaneous infusion.
A lot of the same stuff we just covered.
Yeah, and it's pretty much, it's all the same that was in this presentation. It's
It's a clean procedure, not sterile, right?
correct, yes. And it even goes through, even in addition, removal, how to remove the device. So it's very thorough here. And the kits are available, ordered through the pharmacy, and they're in the IV kit box. So anyone's welcome to take a look at the kit and play around with it. I know through experience that it's worked very well in other nursing homes that we're at. It's really, the nurses really report that it's quick, easy, and we could easily manage taking care of a resident without going to the hospital to give just some fluids for some mild dehydration.
And do you know, in other facilities, how do they get physicians to be on board with that are Optum? I mean, do you think
Yeah.
it'd be appropriate to coordinate like subQ fluids instead of?
You can say we have hypodermal crisis available versus IV therapy. We have these kits readily available, and we have a policy to follow. You can frame that to the physician, and I'll talk with Angela when she returns next time, if she wants to share this with the medical director, that this will be available here.
She did tell me that she plans for us to go through it. Does it just go straight down? The needle?
Yeah, just like in a sub-Q.
Yeah, it's like a butterfly that opens and then it just lays flat. I'm pretty dummy proof. It looks like.
Yeah, I just saw somebody do it at one of the other sites I visited. For somebody who they couldn't get it started 3 times.
How easy is it to go in?
comes off and the butterfly opens. And there's a needle and then these two little plastic things on the side. We can't open this, can we?
You can, yeah, this is just, it's for demo, so you can open it.
Can somebody else open it? There we go. So,
Yeah, but it just comes.
and then you just. I'm sure this blue thing comes off, right?
Just right in.
Yeah. Boom. And then put this little piece on top.
And that's it.